So indications for endotracheal intubation is to protect the patient's airway, as well as relieve upper airway obstruction that the patient may have, also for mechanical ventilation. Some contraindications are facial and or neck trauma, because you can't put the patient's neck in, sniffer's position. Some complications and hazards that may go along with are damage to vocal cords, gagging. The ET tube can erode the corner of the patient's mouth. The patient can no longer communicate. There may also be contamination of the tracheobronchial tree. Okay, first we start off with our equipment. Our gloves, bag and mask, our CO2 detector, our Posey cuffulator. Our ET tubes ranging for adults about 7 to an 8, averaging 7.5 with a stylet. Our syringe, tape, our handle for our laryngoscope, and actual blades. Miller, which goes directly on the epiglottis, and the Macintosh, which goes on the follicula. I'm choosing the Macintosh. First, we're going to put the patient in sniffer's position. Got our tight E and C seal. Okay. Nice and bright. Take my left hand, sniffer's position, insert in the follicula, and lift up to try to get the handle to meet the area where the ceiling and the wall meets. Try not to touch the teeth. ET tube. Take that out. Detector, our bags, and mask. There's equal movement. Look for like bilateral chest rise, or also tape to see if it's in the belly or stomach. Yellow, mellow, not good. Purple shuffle, it's in the lungs. Perfect. And now I'm going to begin to tape. I want to pretend as if there's someone still bagging, but I'm here alone. Spouts. Not that big. Tape. If someone would have a tight hold on this while bagging, it needs to be 2 fingers width. Make our little flags. Pull down the corner of the mouth. The bottom one stays down. And the top one rings around. Making sure this is nice and taut. At this point, I would have also verified that it's the ET tube between 20 and 24 from right here at the mouth. That's enough. I'm gonna make another little flag. I'm gonna take this bottom piece. Still got 2 finger lengths. Make our V, our flags down there. Bottom piece or top piece goes on the face. And we're going to wrap this top piece right on around. About 3 or 4 times. Take it off. Flag it. We're testing it. Not going anywhere. Some bedside methods to assessing tube placement is the auscultation of bilateral breath sounds as well as bilateral chest rise, and you can also get a chest x-ray. 30 milligrams of water per liter is the amount of water that should be provided by a humidification device. And the maximum safe limit for the cuff pressure is no more than 20 centimeters of water. And now to check the cuff pressure. The 2 purposes or uses of the cuff is to prevent aspiration from oral secretion as well as stomach content. The low volume, high pressure has greater than atmospheric pressure, which puts pressure on the tracheal wall. That's why the normal pressure limit should be no more than 20 centimeters of water. In a clinical condition, the cuff pressure should be maintained below normal when the patient is hypotensive. There are 3 ways to check the cuff pressure. The first is the minimal leak technique, the minimal occlusion volume technique, and the Posey cuffulator. Insert a one-way valve adapter onto the cuff inflating tube. The pressure on the gauge should read between 20 and 25 centimeters of water. On this pressure manometer, the arrow should stay in the green. You can use the hand pump reservoir to increase pressure or the pressure release valve to decrease pressure. The other 2 techniques are the minimal leak technique and the minimal occluding volume technique. The minimal leak technique is to determine the cuff pressure that results in a small leak. With the stethoscope beside the larynx, listen for airflow as the cuff is inflated. Inflate the cuff until no airflow is heard, then withdraw air slowly until a slight leak is heard. The minimal occluding volume technique is to find a cuff pressure that results in no leak at the cuff. This is accomplished the same way as the minimal leak technique except the cuff is slowly inflated just to the point where no leak is heard. And now for extubation. Some indications for extubation is the ability to protect one's own airway by presence of gag reflex, normal consciousness, the ability to maintain spontaneous ventilation, and the ability to maintain secretions based on cough strength. In the procedure, you oxygenate and prepare suction equipment for oral secretions post-extubation. Begin by deflating the cuff with the syringe and making sure you deflate all the way. You would find a weak spot in the tape and tear it off. There are two ways you can extubate a patient. One way is to instruct the patient to take a deep breath and at peak inspiration withdraw the tube. Another is to give a big breath with the bag. I instruct my patient to take a deep breath in. At peak inspiration, I withdraw the tube and I pull it out forward. I do this to prevent secretions from flinging. The therapy and appropriate medication for treatment of glottic edema or stridor is a cool aerosol, vasoconstrictors such as racemic epinephrine via a handheld nebulizer, and corticosteroids such as Decatron. Some parameters for determining respiratory failure following an extubation is to avoid oral feeding for 24 hours to decrease the chance of aspiration. I follow up by evaluating the breath sounds, respiratory rate, oxygen saturation, heart rate, color, and blood pressure. And there you have it. Intubation.